The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
How to get comfortable with talking to patients about sexuality and breast cancer.
I just want to go on the record that I am doing this episode under duress because this is not something...
I think part of the reason why we're having this conversation is to help other people, other physicians and people in this.
Are we talking about appearance, sensation? Are we talking about body image?
Is this something we should be bringing up with our patients, or is this something that, hey, if a patient asks...
Are you feeling as uncomfortable as I am, women to women, talking about this?
Being able to say, wow, I need to step up my game and be able to ask some of these questions.
So if a patient is asking you about this, do you think a patient is feeling like I'm abandoning them or leaving them?
When is sexuality to talk about with patients inappropriate, right? So
Yeah, we just got an explicit rating on this episode, incidentally, now, Carla.
We don't have to talk about everything, but being able to identify.
You know, one of the things I think we also need to address is that there are going to be some real cultural issues.
But it's great that there are people talking about that because women need to talk about those things. This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing. Our topic today is how to get comfortable with talking to patients about sexuality and breast cancer. But before we get started, let's begin with some personal and professional updates. Michael, we're going to start with you.
Well, I got the boat that I found in the woods, and I floated it out there. We didn't have any champagne, so I drank a Dr. Pepper and smashed that on the front. And I floated the boat out. We have this little boathouse, and I rowed it to the boathouse and tied it up, and it sank. That's probably why it was shoved off into the woods. So now I've
name the boat?
I've got a name for it now. It's the SS Minnow for all of you Gilligan's Islands fans. It's got a hole in it, and it's at the bottom of my boathouse, so I don't really know how I'm going to pull that up, but there it is. So I've got to get a new boat, but first I got to pull it up out of the water. So boating is not for me. Another hobby that has now gone terribly awry. Carla, please give us some better news than what I have for us.
My news is not that exciting. I always say it's hard to follow you. You always have these fun updates.
Awful.
I had a busy spring. We all were in person not too long ago in Seattle, and I got back to Indianapolis, and then I headed off to the East Coast and help my dad recover from his other knee surgery. So got to spend some time with my parents and feel like a useful daughter who's giving back to them. So I was doing a lot of Zooms and trying to catch up on things while being away from work for like a week and a half out of 2 weeks. So it was busy for me. What about you, Susie?
So my latest adventure is our family went to a lantern festival, and these are super cool. So you kind of hang out all day long. There's bands, there's food trucks, you can get permanent jewelry, whatever, the whole park vibe kind of thing. But then you get these giant lanterns, and they're made out of paper, and maybe go up to your knees. And after about an hour after dark, you light a little disc on fire, and it becomes like a hot air balloon. And you can write messages on them, of course, before you light it on fire. And then about 10,000 of these go out into the sky at the same time. It's so magical. And then, of course, my husband was asking questions about what happens if things catch fire, who cleans up the trash. And I'm like, buddy, stop ruining the moment.
The lanterns are beautiful. I hope it was a beautiful night for that and very spiritual.
It was really, really neat. Okay, so let's move on to our topic, how to get comfortable talking to patients about sexuality and breast cancer. For many of us, discussions about surgery, pathology, treatment plans, those are pretty easy. I mean, they can be hard, but they feel natural. Conversations about sexuality, intimacy, body image, even sexual function, those can be a lot more challenging. But some of these quality of life issues are so important for our patients that they're facing during treatment. And today we're going to talk about why these conversations matter, maybe what holds us back, and how do we create a safe zone for our patients to talk and ask questions that maybe don't have a voice, might feel embarrassing. Who wants to get the conversation started?
I just want to go on the record that I am doing this episode under duress because this is not something that I excel would be a very strong. I just don't enjoy this. And I know it's important. I can talk about body image. I can usually do that with my patients. Once it gets beyond that, it just gets a little creepy for me. And I tend to do poorly at that. Now, fortunately, I've got great PAs who step in and can really have that discussion. And I'll step out of the room because I think it gets a little touchy. I mean, especially just being a male. I usually leave that to them. But this is a hard topic for me. Males talking to females about intimacy and things like that. I can prescribe medicine and we can talk about vaginal dryness and things like that. But once we get beyond that, I am usually trying to tag out.
I think part of the reason why we're having this conversation is to help other people, other physicians and people in this space understand some of those things. And none of us are experts. That was the first thing I was going to say. I'm probably not an expert on most of the things we talk about. I know a little bit about a lot of things, but I do think it's important. We bring on experts for some of the topics that we talk about. We're very thoughtful about that. But this is something that I would not proclaim to be an expert, but I think I can raise maybe some interesting questions or bring up some important points. But I don't think people are going to always feel natural talking about these things. And I think that some people might get better about it, and it's important to understand why it's important to our patients. But this may be one of those topics that just you will never excel. It will never feel natural to you. And I think it's okay. So part of our discussion is going to be, how do we learn those things, or what other things do we rely on to benefit our patients? And you've actually already mentioned one of those. So when I was thinking about this, I was thinking about the team approach. I mean, this isn't a team thing where you're going to have a conversation with 10 people, but kind of saying, you know what, this isn't what I know the most about, but I know someone who can talk to you a lot about this, or somebody who might be more comfortable. And so I'd be interested to hear maybe what resources people have. And we all practice in slightly different places. So Susie, you have a program and lots of people that you've talked about at different times on this podcast. Is this a topic that you confront, or is this a topic that you have other people that patients can talk to about?
So I have to say, like with this podcast, it continually makes me grow as a surgeon. And I don't think I would have embraced this as much until I knew this was part of the topic, and being able to say, wow, I need to step up my game and be able to ask some of these questions that I do feel uncomfortable asking people about and directing them to people who have more expertise. And I think, Michael, you brought up an excellent point. Are we talking about physical symptoms such as vaginal dryness, pain, fatigue? Are we talking about appearance, sensation? Are we talking about body image? I think sexuality can mean so many different things. I mean, it's not necessarily just the act of intercourse, but it can be intimacy or it can be connection. And knowing who on your team is really going to be able to ask these questions.
Do you guys feel comfortable talking about that? I don't feel as comfortable, but are you feeling as uncomfortable as I am, women to women, talking about this?
From a clinical standpoint, I think it's an important question to ask, but I might not be the best person to navigate different things through that. And that's why there are people who are certified in this area.
Yeah, I think just because we're physicians or we're breast surgeons doesn't mean that we need to be comfortable talking about sex or sexuality at all levels. And that's why I said before, this does not need to feel natural, and it's okay. People are going to have differing layers of it. So I think part of it is, how do we establish what is the baseline? How do you make patients feel comfortable talking to you about this, or at least asking questions of like, I'm having vaginal dryness. Should I be talking to you about this? And I think we all agree that it's okay to be like, I'm not the expert, which maybe we should be, but also here's who you could talk to, or I know that there are some creams that you can use. Let me have my nurse talk with you about that. And so I think defining what we're talking about is important, Susie. And you said, is it this? Is it that? Is it that? I mean, it's kind of all of those things, right? So sexuality is kind of a vague term. I think sexual function is getting more specific. I think body image, as you talked about in the beginning, Michael, might be the first thing that a lot of us are a little bit more comfortable talking about, just because we're talking about surgery and breast surgery. Susie, you do general surgery, right? You take someone's gallbladder out, it affects them, but that doesn't affect their body image for the most part, other than maybe a small scar, and those scars just keep getting more tiny. And so I think body image is something that's part of this that we do talk about. One of the questions I had in thinking about this, and it was brought up, is this something we should be bringing up with our patients, or is this something that, hey, if a patient asks me, I should be prepared to talk to them about it? So what do you guys think?
I definitely think we need to be bringing it up, because I would be the person who originally was like, oh, if they say something, I'll answer it. But then I think about a lot of people who might be more shy or might not feel that it's appropriate to discuss, or they don't know, who am I supposed to discuss that with? Is it the medical oncologist? Is it the surgeon? Is it the OBGYN? Who do I talk about this with? And so I think it is our responsibility to ask about it.
The body image is easier for me because you will see a lot of patients that their default is just remove the whole breast. And we start saying, look, it may not matter to you. Tell me it doesn't matter to you now. And it may not matter to you now, but it's going to matter to you in 5 years or 6 years when reconstructed breast doesn't look good, or your breast prosthesis is riding up and things like that. So I can easily address those factors of it. As far as being very proactive on some of the other things that maybe some of the tamoxifen causes or the AIs cause, I have not been as proactive on asking those questions, because I usually leave that to medical oncologists. They're causing it, so let them deal with it. Now, turns out if they're asking me about it, the medical oncologists aren't dealing with it either.
We all have to bring out our inner Susan, right? She's not here, so we have to sort of challenge things. But one of the things, the themes that I say a lot is that we're asked to talk to our patients a lot about things. So we talk about surgery and medical treatment and radiation. We've talked about financial toxicity, and okay, let's throw in sexual function as well. So if you think that that is something that we should be proactively bringing up, can you tell me specifically when you would think about that? Is it an initial visit when you're talking about breast cancer treatments? Is it at their 6 month or 1 year, or kind of like just a follow-up visit? When do you think is the right time?
I think a couple of things with that. I think when we're initially talking about surgery, and like how Michael is describing, a lot of us are comfortable saying, okay, if you undergo a mastectomy, you may lose sensation. We do have techniques now where some of that comes back, but maybe not erogenous sensation. And to go through that, we want to get rid of the cancer, but we also want you to be able to look in the mirror and be proud of yourself, even if it's after a partial mastectomy. So I think that type of body image conversation at that point is part of what we do quite often. Post-operatively, I think especially after they're getting some adjuncts, maybe it's chemotherapy or endocrine therapy or radiation therapy, I think it's okay to do a check-in. And I think it is okay to ask, are you having any symptoms? And being specific. Since I have started doing that, I have been surprised how many women have started talking more about vaginal dryness or fatigue and how that impacts them. And I find that some of what they are really seeking is connection, and maybe connection in a different way that's not related to having actual sexual intercourse. And how do you work through that and direct them to the correct people? At our hospital, we do have workshops with someone who is certified from the American Association of Sexuality Educators, Counselors, and Therapists. And I had to look this up. The American Association of Sexuality Educators, Counselors, and Therapists. And it is a real certification for people with different levels, whether they be coming from a social work background, from a therapy background, to be able to have some more of these in-depth conversations. And it might be about physical touch, and it may be about connection, but it is really about being able to experience joy in whatever form that may mean.
So you've got somebody that's certified in that?
Yeah, and as I started talking to people about it, I found that this is like a real thing. Like, you can go online and find someone near you for that. But we do have some workshops, and they are always sold out. This is a big need. And by seeing that they were sold out, I was like, oh, this is really a thing.
And I think those are the conversations that we bring up when we talk about those things. Again, we're not going to become an expert, but guess what? There actually are people who are experts that you have access to, which I think is really helpful. One of the things I'll make a plug for, I think a lot of our listeners are probably familiar with the BreastQ patient-reported outcomes validated questionnaire. So we use it a lot for some of the research that we do, and we know that there can be preoperative and postoperative modules. And we tend to be really good at coming up with the research questions sometimes after the fact, and then asking patients after the fact, like, how do you feel about your body image and how do you feel about your sexuality? But there's a reason why getting those preoperative measures can be really helpful. And I'm not saying that we all need to start doing that, but you were saying, Susie, it's like, if you look in the mirror, are you happy? Are you proud of? And I'm sure, unfortunately, there's a lot of women and men who would say, well, I'm not happy with that now. And that's one of the challenges we deal with as breast surgeons, because we might be taking people at a certain point in their lives where what we do is going to affect how they see themselves, but they already see themselves a certain way. And maybe it is important for us to intervene and use that as an opportunity, but it's also a challenge, because if they're not happy with how things look or feel now, I can't fix that. I might make that worse. How do we minimize that?
Carl, do you use that on every patient, or is that just in study patients?
Good question. I would love to say we use it in all patients. I know a lot of it, some institutions do. We are in the process of getting EPIC and very specifically putting that in there, because as we all know, patient-reported outcomes are important, and they're becoming more and more important for these types of reasons. And I think figuring out what the issues are baseline, because then we know whether or not our interventions affect that, right? So sexuality and sexual function, I mean, is everybody firing it 100%? No. Are we making it worse? Probably. But sometimes we blame a lot of it on the cancer treatment, but we haven't really assessed it preoperatively.
It would be a nice thing to do for a prompt. So instead of having to say, how is your intimacy going? I mean, if you've got it in black and white and you see a dip in a score, there's a prompt, and then it can be addressed in however you choose best to address it.
I was reading some statistics that it's like 80 to 90% of breast cancer patients have a change in their perceived sexuality after surgery. That's really, really high. And if I'm not asking about it, I'm not able to intervene. And I agree with you, Carla. What are we intervening on, and what's the baseline? Because some people could have struggled with body image issues prior to surgery, and this just added to it.
So if a patient is asking you about this, Do you think a patient is feeling like I'm abandoning them or leaving them with somebody?
You're listening to the Next Breast Thing podcast. We'll return in a moment after this brief message from our sponsors.
Breast cancer recurrence doesn't wait for symptoms. Signatera is a tumor-informed circulating tumor DNA test that detects molecular residual disease months before imaging. From neoadjuvant response to long-term surveillance, get unparalleled insights to inform next steps. Signatera is backed by Medicare coverage and more than 175 peer-reviewed studies. Learn more at natera.com/Signatera.
And now, back to the Next Breast Thing.
So if a patient is asking you about this, do you think a patient is feeling like I'm abandoning them or leaving them with somebody who they may feel more comfortable with? As I say, I tell you what, I'm going to step out of the room and let you guys discuss this a little bit more in depth. Am I showing cowardice, sort of handing them off to somebody else?
No, I think people should talk about sexual health with people who are comfortable on the treatment team. I mean, that could be anybody. That could be a nurse. That could be a PA. That could be a therapist. That could be a counselor, a social worker. I mean, we have a lot of people who have gifts, but I think it's important that we're asking questions and making the connection. There's a difference between a medication that might be beneficial for, say, vaginal dryness versus how do you become more intimate with your partner, which may not mean sexual.
Yeah. I watched somebody who was probably in that association you talked about, Susie, sort of talk about sexual function and intimacy. And I mean, this woman was talking about vibrators and dildos. And I'm not going to have those conversations, right? And Michael Berry is not going to have those conversations.
Yeah, no, we just got an explicit rating on this episode, incidentally now, Carla. Thank you.
But it's great that there are people talking about that because women need to talk about those things. But yes, that probably goes beyond what we do. I will say something you said, Susie, really triggered me in terms of just thinking about something. But since we've been talking about nipple-sparing mastectomies and nerve preservation, that has given me a good opportunity to talk to patients about nipple sensation, erogenous sensation, because I will often say it seems to help protect with sensation, kind of feeling things up against there, whether it helps with sexual function or sexual intimacy. I think we're still figuring out. It's a nice way for me to introduce that without saying you're going to have a mastectomy and you're not going to feel your nipples ever again, because that's not how I want to lead these conversations when we're talking about breast cancer treatment. And that's why I brought up when you bring these things up with patients as well, because I struggle with the let's talk about your breast cancer treatment. And by the way, you might have some sexual function issues and body image. Talking about that day one.
Day one is so overwhelming. I agree with you. I think one of the themes that I really feel is important is that people aren't ashamed to talk about any of these things. And we may not be the right resource, but we should be able to direct them to the right place. And I think it's okay to, where you're comfortable, you're staying in your zone is fine. If there's people who are more comfortable with, I don't know, maybe some of the advanced therapeutics in this area, that's okay too. We don't have to know everything, guide everything, talk about everything, but being able to identify this is an issue for that person, and they shouldn't be embarrassed to bring it up.
You know, I want to give the surgeons some kudos on this, though, because I think we've been pretty preemptive. I mean, the whole fact that we do breast conserving therapy is knowing that the body image is better with breast conservation. The fact that we push so hard for reconstructive surgery after a mastectomy, and the fact that we are preemptively doing nerve preservation or doing techniques that may salvage nipple sensation. There's a lot that we're doing on the front end because we know that what we're doing is causing a problem or trying to prevent that from ever becoming a problem, or at least ameliorating it in some sense. I'll give us a little bit of credit for recognizing that it's an issue and working to try to get over that hump.
Yeah, I really love the advent. I mean, it's not even the advent anymore, but really people being very thoughtful about their incisions and this oncoplastic movement of, yes, we 100% have to get rid of the cancer. And we also want you to look good and be proud of your body.
And I would give a shout out to patients as well. I think surgeons have done a great job listening to patients, but I always say we're very thankful and appreciative of our patients when we talk about clinical trials, but the feedback and information that we've learned from them about what's important. And the breast cancer community in general has really listened. When is sexuality to talk about with patients inappropriate, right? So we're kind of talking about how to make things comfortable, but this can be a delicate and sometimes beyond uncomfortable conversation. Michael, you kind of talked about sometimes as a male surgeon and a female. Obviously, we have sometimes nurses and MAs who go in when you're having a breast exam, sort of for that reason, just to kind of make sure that everything is kosher. Have you guys ever dealt with a situation where it feels like it's a sexuality comment beyond just having a good conversation about sexuality after breast cancer treatment?
Yes, I have been shocked sometimes by what patients will share. I do remember this one time. I had a patient who was going to sleep in the operating room and the anesthesiologist was, pick out a great dream. And she was so funny. She's like, I'm wearing a red fur coat. I'm in Chicago. It's snowing. And the anesthesiologist was very conservative. He was like, and she's asleep. It was pretty funny in the operating room having her tell what her version of a perfect dream was. And everybody else was like, what? This is really uncomfortable. So I think we do have those opportunities where we're hearing some things that might be different than what we think.
One of the things I think we also need to address is that there are going to be some real cultural issues. We'll encounter this a lot of times with certain faiths that the husband is there the whole time and will not leave the room. And we're okay with that. But what is that patient's freedom to speak about some of these things or discuss these because it's just not seen as appropriate? And I don't know how to address that because it can be stifling to them to go into these issues.
That's such a good point, Michael. How do you read the room and know where this is appropriate, where it's not? And I think a safe ground can be in terms of how do people appreciate being appreciated. It's not the love language that they necessarily love to give, but it could be how you like to receive it. And maybe it's not just about sexuality, but how do you feel comfortable?
I will say I've seen that come up if we're kind of referencing the body image, where we've had scenarios that we've had to discuss as a group where maybe a patient seems to be interested or wants a mastectomy because she needs it or she desires it, but the significant other in the room is sort of saying, no mastectomy, I don't want your breast removed. And there seems to be some underlying stuff that you're picking up on there. I think every breast surgeon has probably been in a scenario like that. And obviously, as women, we tend to think like, oh, I want to have a one-on-one, but with my patient and with another woman, and I want her to kind of voice what she wants. But like you said, in some cultures, that is totally appropriate for the husband to be a part of that and speak up. And that's not something I understand very well. And part of me understanding and respecting that is knowing that not everybody approaches that the way I do. And I do understand that, but it can be a challenge. And I think you look for those moments where you can perform a breast exam, maybe without family members in the room, if it's appropriate, and have an opportunity to ask those tough questions. I guess I'll circle back to the appropriate or inappropriate. I mean, when is sexuality kind of talking about that with a patient, drawing the line? And do male breast surgeons have to think about that different? I mean, sexuality is all sorts of things these days. One of the things I'll put my fellowship director hat on, and Michael, you've certainly done this as well, but teaching your trainees, so general surgery residents and breast fellows, to understand situations. I mean, whether it's a conversation you're having or just your safety, unfortunately, these days of this is a conversation I need to end right now and leave the room. And maybe we can come back and have this discussion, but I need to bring somebody else in with me. Or maybe I'm leaving the room and I'm not going back.
I agree. It is a teaching point because you've seen a lot, you've done a lot, when these conversations start, you kind of know where they end up. And I think teaching the fellows that this is going to need to be addressed and how best to do that and teach them. Again, not that I'm great at navigating it, but sometimes you'll see these things coming and can gracefully move to a PA or redirect or talk in more broad sense than sex toys or things to that nature.
I think there's a difference too between slinking out of a room because you're not comfortable versus saying, I'm going to leave this topic to my PA because there's plenty of male OBGYNs too who have to have an intimate exam and have conversations about this. And so I think we all can bring ourselves to the table to ask questions. And when it crosses that line, it is okay, I agree, Carla, to call in reinforcements or to say, hey, can we pick up this a different time or figure out how to close that conversation on there? Because I think we have to protect ourselves And I think it's important that we are able to have these conversations because this is not just necessarily a physical aspect that we're dealing with, but it also can be someone's mental, emotional health. And again, going back to connection and just feeling that they are loved for whatever reason that is in whatever environment, I think is important.
One of the things I want to put a plug in for is our episode on HRT or MHT, as we learned. And while a lot of the things we talked about, we didn't get into hormones per se, we talked about anti-estrogen therapy. We referenced it a couple times. We talked about vaginal dryness, which we know is a big thing that comes up. And certainly for women who don't have breast cancer but are going through hormonal changes, we know that sexual function can change for many reasons. It's crazy because since we've had the episode and had the meeting, I cannot tell you how many patients I've had conversations with who either had breast cancer or are high risk about starting or stopping hormone therapy. And it is not because I'm paying attention and I'm bringing it up. It is really just all around us. I always like to say kind of the big points to come away with, reference different people in this space if you're not the expert, but also better understanding how hormones can help your patient in this space and what is safe and what is not safe. Because we know that the days of saying like just no to hormone therapy, they're gone. They're gone.
That is a great point. Go back and listen to that episode if you haven't heard it already, because it was packed full of stuff that dogma has just kind of flown out the window. And I learned a ton in that episode that I had no idea, and the newer research and the newer developments that have come along. And I think she did it very safely too. It wasn't just this blanket statement that, oh no, you can go right back on hormones. But the way that she presented it, I thought was great. So go back and listen to that episode if you've not heard it.
I think that's what's so special about this podcast is that it promotes curiosity and what is the next question. And even for all of us who are on here, Michael, what is your takeaway from this episode?
I think Carla sort of said it when I was sort of squirming in my seat over here, that it's okay to use your team and have a plan for that. Know who it is on your team that is better served at having these discussions than others. If it's you, then great. Then you assume that role. If it's somebody else, let somebody else assume that role. But this is not really a taboo topic. We're going to need to discuss it. The patients need to have the ability to discuss it and just see how that works best in your team.
Carla, what about you?
Part of this uncomfortable conversation is the relationship that you build with patients, which is important to all of us as breast surgeons, which is trust and creating a place of comfort in your office. And so I think starting from there, you'll learn more. And I think the other thing is
American Association of Sexuality Educators, Counselors, and Therapists.
Yeah, these people exist. Figure out where they are in your community and connect with them.
Yeah, I agree. I think also for me is just being more eager to learn about the cultural impacts on this conversation. And I think being comfortable, being uncomfortable with certain conversations and allowing this to not be filled with shame and walk with people through that. So anyhow, this has been an amazing conversation that we've been able to have together. And to our listeners throughout the breast community, we are so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.